Hi, I'm Gavin Giovannoni. I'm a neurologist based in the East End of London. I'd like to thank you for joining me today on this Moving Science MS podcast, where we'll discuss the future promise of artificial intelligence and the use of real-world data in multiple sclerosis. With me today is Dr. Benjamin Friedrich, co-founder and chief medical officer at Medica in Germany. Welcome, Benjamin. Maybe you could start by telling us something about your background and how it relates to real-world data and artificial intelligence.
Sure. Thank you so much, Gavin, for having me. As you said, I'm the co-founder and chief medical officer of Medica. I will get to Medica in a second, but from a background, I'm also a physician. I always wanted to be a doctor, and I studied medicine in Germany and in Ireland. And already during my time at the university, I almost fell in love with the brain as being that marvelous, incredibly fascinating organ system. So I decided to follow that passion, and I stayed in Ireland and did a postdoc in basic neuroscience in Ireland, and then came back to Germany and did my training in neurosurgery and neuroradiology. Besides working in the hospital, I always also did a lot of research. I built up my own research group, became an assistant professor, and had been working for 10 years in university medicine. And of course, during that time, I saw many things that are working out great in the healthcare system, but I also saw a lot of things where, at least in my opinion, the healthcare system can be improved on. And from that, really, I felt more and more the need that there is actually abundance of data available out there. Data that patients, physicians, healthcare systems are sort of creating on a daily basis. And I felt that this is a lot of untapped potential, actually, that we should leverage to improve the treatment reality of patients and improve the healthcare systems. So long story short, after 10 years of university medicine, I decided to jump into the adventure of building up my own company to make my vision a reality, to create something where we can really leverage real-world data and AI to improve the lives of patients and improve the healthcare system. And that was really the starting point of Medica. Medica is, we are not a real startup anymore. We are based in Munich, a little bit more than 120 employees, and we define ourselves as a health insights company. So that means that we create new relevant scientific and health-related insights based on multiple different data sources that we are combining and analyzing using state-of-the-art technologies like artificial intelligence. And besides that, because I said my initial point was that I really wanted to improve the life of patients, is that we are building digital solutions, apps, for patients with most of the time chronic diseases to support them on their disease journey and to really give them a digital tool that is accompanying them. And one of those tools that we have created is an app in the area of multiple sclerosis, which is called Breeza, which is available here in Germany.
Yeah, what an interesting journey and a background. And I think it illustrates the point that a lot of problems need solutions with people that have varied backgrounds, and you're probably an example of that, taking your neuroscience, your interest in medicine, seeing how healthcare systems are pretty dysfunctional, in my opinion, and then going into the private sector to find a problem. Okay, before we actually get onto the questions around real-world data and AI, maybe I should ask you a very broad question, given the complexities of MS, because it is a very complex disease. What do you think are the current primary challenges that you see in research and the management of the disease today? And how do you think these will impact treatment approaches going forward?
So multiple sclerosis is a prime example of the, as you said, complexities of diseases that are infecting the central nervous system. When you look back into the last years and decades of research, we really have come a long way. We are understanding much better nowadays what multiple sclerosis actually is, what the reasons, what the cause of multiple sclerosis is, what the traditional course of the disease, the development of the disease actually is. And by that, we are now at that point in time that we are more and more understanding that it's actually not just an inflammatory disease, but it is including some components of being a neurodegenerative disorder. Of course, you are one of the leading experts when it comes to the whole topic of, is there an infectious component part of multiple sclerosis? So basically, the more we learn about multiple sclerosis, the more we see that we haven't understood it fully at all. And we need to learn a lot more about these things. And following that, I think what makes multiple sclerosis so special is really the diverse symptomology that patients suffering from multiple sclerosis are having. So from motorist symptoms, sensory disturbances, cognitive impairments, there are a lot of different symptoms that are actually associated with multiple sclerosis. And that makes it so incredibly complex nowadays to diagnose it, and especially once a diagnosis has taken place, to follow up and manage those and treat those patients properly. And when you take into consideration these diverse symptoms, you really fast end up by the individual patient that there is a huge variability when it comes to the individual symptoms of an individual patient, when it comes to the topic of how fast and how in general is the disease progressing in an individual patient. And therefore, also the response to treatments vary widely across patients. So that makes it even more complicated to establish standardized treatment protocols. And of course, we would love to identify patients as early as possible to treat them. And again, coming back to the wide range of symptoms patients can have, that makes it very, very hard to detect and identify patients at the very, very early stage of the disease, or even potentially patients that are at risk of getting the disease. And the same holds true when it comes to monitoring the progression. When you have all these wide different symptoms, it's very, very different to identify, is the patient progressing, yes or no? In what area and what symptoms are patients actually progressing? So that's one of the main issues here. And when we're talking about something that is so complex, that is so variable, that is so different between patient to patient, I think we have, and that brings us already to the topic of real-world data, we have an issue when it comes to clinical trials, when it comes to the development of new therapies, because inherently the way clinical trials are designed, you have to basically build cohorts that are sort of standardized and that are excluding somehow the individual course of the progression in an individual patient. So the generalizability of a clinical trial to the individual patient is actually, in my opinion, a big challenge. And of course, last but not least, we're talking here about innovation and the future outlook. I think we are now really at the cusp of learning and starting to incorporate and integrate all these exciting new possibilities that we have, talking about real-world data, artificial intelligence, and technology in general into the diagnosis, the treatment, and the monitoring of patients. So yes, very, very complex, but also a super interesting and exciting time, I would say.
Yeah, I mean, I have to agree with you. I think, based on my worldview of MS, although we have this classic, what I would call McDonald type view of the disease, which is basically defined by, what we as clinicians see clinically and on MRI, definitely misses majority of the disease, and we have to actually, I think, rethink our approach to MS. So maybe this is an opportunity for, obviously, for technology to come in, but also for leveraging real world evidence and artificial intelligence to maybe change the way we think about MS. So maybe we should now move on to real world data in multiple sclerosis. Maybe we should just start for the listeners by defining it. Have you got a working definition what you use for real world data?
It's great that you bring that up, because more often than not, I have the feeling that it's a little bit all over the place when it comes to the definition. So my personal definition of real world data is actually basically all data that are being collected outside of a structured clinical trial setup. So basically all types of data that are being collected, gathered, stored in the real world setting. And that is, for example, that can be electronic medical records that every physician is compiling about their patients, or hospital records. But of course, also insurance claims. So insurance companies, they have a lot of extremely relevant data about their patients. Then patients themselves, they collect a lot of extremely important data, being it just writing down notes about their symptoms in a paper journal. That's already real data, although admittedly hard to use. But if they are using apps, if they're using wearables, mobile devices where they're tracking their daily step count, how they're feeling. And last but not least, things like social media, like internet communities where people are sharing, patients are sharing about their experience with their disease, what had helped them, what maybe was detrimental for them. So all of these types of data are, for me, basically real-world data. And sometimes they're very structured, like I mentioned before, in electronic medical records, but they can also be extremely unstructured, like in social media.
So you're probably aware of registry trials. So this would be real world data. Would you classify that as real world data when you do a trial within a registry?
Yeah, that's a very interesting question. Actually, I think it's a little bit of a gray zone. Let's put it there. Yes, you are including patients out of the quote unquote real world. Yes, they are not primarily participating within a clinical trial. Nevertheless, patients that you are enrolling and including in a registry are in a controlled environment. There are inherent biases, which patients you enroll into the registry, which data you are collecting in that registry. So therefore, I think for me personally, but I would also be curious to hear thoughts about that. But for me personally, it's a little bit of an intermediate gray zone. So usually when I'm talking about real world data, I wouldn't exclude registry studies in that.
Because I suppose from a MS perspective, will the regulators, the European Medicine Agency and the FDA accept, real world data as sufficiently good quality, whatever, to license a drug or change the label, for example? Do you think we're going to get to that stage where the regulators would accept this?
Let's put it that way. I hope definitely, and I hope the sooner the better. I of course know why, and totally understand why there is some hesitancy around that. But let's put it that way. I'm 100% confident, and I'm 100% sure that within the next years we will actually see a tremendous revolution when it comes to that, and the authorities will start to accept more and more real-world data to really support substantial medical claims and also the authorization of drugs. I mean, when you look into developments that are happening nowadays, already the first clinical trials that have been accepted by the FDA, for example, which have been based on something which is called a synthetic control arm. Maybe I explain that in just a little bit more in detail for our listeners, because maybe not everybody is so deep in that material. So as everybody most likely know, a clinical trial most of the time is being constructed in the way that you have two groups that are being compared against each other. So the one group that is actually getting the drug, the treatment that you are testing, and one group that is usually the control group, which is either getting a placebo or getting the standard of care. And these two groups are being called arms. So there have been some projects, some studies conducted in the past where that control arm actually was not de novo or newly enrolled in that study, but the control arm has been constructed out of real-world data that had been established already from other sources. And there have been trials that accepted actually that type of study design, where you just have the one arm that is getting the new drug that is being tested, and that is being compared to historic groups. And of course, this type of study design has a lot of advantages. It makes the whole process way easier and faster. And primarily, it has a lot of advantages also for the patients, because you just need to enroll patients in that one arm that is actually getting the substance that you want to investigate, and therefore the risk of side effects, etc., for patients is greatly reduced. So I think that there is a lot of things going on at this point in time. I would love that the authorities might be a little bit more courageous when it comes to testing new ways of working, or incorporating real-world data a little bit more in detail. But we will get there. I'm 100% convinced.
Well, maybe to bring this back to MS, then maybe you could just give some of our listeners, two or three examples where real world data has really impacted on research and patient care.
Sure. I mean, luckily, the number of examples where real world data has actually been leveraged to create new insights is in generally growing by the day, and especially also in multiple sclerosis. So you mentioned before registry studies, and therefore I would like to touch point on that. So there have been, for example, multiple studies that have been conducted on this intermediate type of real-world data from, for example, the MS-BASE registry. And those data have been leveraged enormously to really identify specific factors that are influencing the disease progression and treatment responses in different subtypes of patients that had not been tested or analyzed in the clinical trials to the fullest. Or another example that, of course, comes to my mind is when I'm talking or thinking about the digital solution that I mentioned before that we have developed, which is called Brisa, that app for multiple sclerosis patients in Germany. So within that app, patients can actually track their individual disease progression based on a standardized set of medically validated questionnaires. And we had the opportunity with some collaborative researchers to go into that data and really to analyze the patterns of symptoms that patients actually are expressing. You remember I mentioned before, one of the challenges that I see with multiple sclerosis is that big heterogeneity between the individual symptoms across individual patients. And so we had a look into what types of symptoms occur in combination in patients and identify if there are potentially specific subgroups of patients. And actually, that was the fact. We could find that the specific combinations of symptoms were actually strikingly different across different patient populations. And that, of course, is an extremely interesting starting point to, from then, start to develop potentially new ways of diagnosing patients, treating patients, or monitoring the progression of the disease within those subtypes of patients.
Yeah, so another example that comes to mind is work on the administrative data in Canada, for example, showing the link between comorbidities, particularly vascular comorbidities, and poor outcomes, so the contribution of other factors to MS outcome. There's also other data that's come out of there showing the importance of the prodrome, before people get diagnosed with MS, the increased healthcare utilization. So, as we go through MS, and as I sit here talking to you and thinking about it, there's lots of examples of how real-world evidence has contributed to a lot of information about MS, which would never have come from randomized trials, or it would have taken a much larger trial design to do that.
Exactly. So that's really the point. I think this is we cannot stress that enough. Real-world data is not there to replace clinical trials. Clinical trials are an extremely important part in our toolkit when it comes to really identify cause and effects and to really limit biases. But nevertheless, there are so many questions that are in desperate need of answer. You will never be able to design clinical trials for each and every question. And the smaller the patient population actually gets, the more impossible it will be to develop a clinical trial that is going to answer that question. That is really the point where real-world data and real-world evidence is extremely important and extremely helpful to fill in these gaps that we are having in our knowledge base.
So clearly the revolution that's occurring in real-world evidence is very promising. But, what are your challenges right now, particularly when working with, new technology, new platforms like apps in terms of getting, good quality data out? What are the biggest challenges facing the community?
In my opinion, it's actually two things. The one topic in general, and maybe we touch later on that when we're talking about the ethical implications, of course, of using real-world data. But as I said, maybe let's touch a little bit later on that. But when we are talking about it from a pure data and technology perspective, the main challenge, I think, in utilizing real-world data is actually to address the variability in data and data quality. Sometimes these data are, to be honest, extremely messy. I mean, within a clinical trial and to some part also in a registry, you sit down in the beginning, you really think about, okay, what data do you want to collect? You create a very clean table structure on when to collect which data in which format, et cetera, et cetera. And everybody is really sticking to that across the whole time of the clinical trial. In real-world data, it's a complete different thing because most of the time, the data has never been meant to be used in that way. So very often they are extremely messy in the sense of they are completely unstructured. Think about the example that I gave when we're talking about analyzing social media data, analyzing about what patients are actually talking about in the internet. So this is text, this is patients talking in written form, and trying to distill and condense the information that you can analyze, that you can quantify, that you can measure it is extremely difficult. But you don't have to go to such an extreme example. Also, when you think about other real-world data sources that I mentioned before, let's take the example of insurance claims. Yes, they are super structured most of the times because there are databases where the insurances are tracking their data. So there is an inherent structure already in there. But nevertheless, very often those data have never been meant to be used to answer the question that you actually have at hand. So standardizing the data across different data sources and structuring them in a way that you can analyze them, quantify them, and derive meaningful insights out of them. And of course, last but not least, to also apply artificial intelligence potentially to those data. That is really the core challenge that one is having when we're talking about real-world data, in my opinion.
Well, that's a good segue or transition into AI. Now maybe we should explain to our listeners about how AI is currently being applied to MS research and care. Maybe you want to give us some examples from your experience of using AI.
Yeah, as you said, it is really an exciting point in time, I would say, that we are in. I think everybody of us is aware and has witnessed the beginning of the AI revolution in the last 1.5 years, but it's actually something that is going on for a little bit longer already, and it's now has become just more and more present to the public. So right off now already there are, I would say, two core streams where AI applications in MS research are actually being applied on. So the one thing is the whole topic of predictive analytics. So what do I mean by that? As I said multiple times now already, multiple sclerosis is extremely complex, super heterogeneous. AI is really, even today, already helping us to streamline all of these information and to identify specific patterns in patients and in their symptoms, to identify their individual disease progression, their individual response to specific therapies, and potentially also to identify their outcome to different diseases. So this is already being worked on for quite some while, and there are now the first really promising results that are on the line. The second topic is, which of course plays an extremely important role in multiple sclerosis, is the whole area of diagnostics. And within diagnostics, especially imaging, MRI imaging. As I said in the beginning, I'm a neuroradiologist by training, so I spent in my life countless hours looking into those MRI images of patients from multiple sclerosis, identifying lesions, counting lesions, quantifying lesions, assessing the edema, but also trying to identify if there is some neurodegeneration happening. And this is a very, very tedious process, and also something, to be honest, I hope I don't offend anybody of my fellow colleagues, but something that honestly we as human beings are not very good in, because it's very, very subtle changes very often, and that is extremely difficult for our human eye to identify. So analyzing those images that are being generated with artificial intelligence is something that is being used on now, more or less standardized across the field, that you really see the changes in MS lesions and especially in neurodegeneration, and therefore can monitor and identify those patients way more sensitive than any human neuroradiologist could actually do. So I would say it's those two things where really AI is starting to enter the field of MS research and MS treatment, and it's really changing the landscape as of now.
Yeah, so I think, even when you look outside MS, anything to do with image analysis is going to be transformed. I mean, I look after some people with MS who've got type 1 diabetes, and, their retinal screening is not done by ophthalmologists anymore. It's done by AI algorithms. And I think if you've seen some of the studies that have come out, the AI algorithms outperform the ophthalmologists in early detection of diabetic retinopathy. Also, just assessing a medical retina, they're better than ophthalmologists. So I think if you're working in the field of image analysis, even if it's pathology, for example, these AI engines are going to, I'm not saying they're going to replace pathologists and radiologists. They're likely to, complement them and free up their time so they can spend their time more efficiently doing better things, for example. But I completely agree. This is going to, transform the field. It's happening so quickly, though. I mean, do you see any particular trends, particularly in neurology and MS, where this is going to transform out the way we practice neurology?
Yeah, that's a very, very good question. So you said it's happening extremely fast. So in my opinion, identify or really pinpointing the way the future is going to look like is extremely difficult. But yes, there are some trends that I would say are happening. So the predictive analytics that I mentioned before in really identifying the individual responses and progression of patients, that is something that will continue and will improve on, I think, dramatically in the next years and decades. Because, as I said before, nowadays, more often than not, single factors are being included into the models. It's either the demographics of the patients or it is the imaging of the patient. So you are looking at all these different influencing factors very often individually. But what AI is really good in is really taking into considering a hell of a lot of data that we as a human being just can never comprehend. So when you start to take into consideration in these models multiple different other data types like genetics, but also environmental factors, where are you living, what's the state of the environment that you are in, behavioral factors, how much are you exercising, what food are you eating. When you can include all these different variables, I think the models of predicting and plotting one's individual patient course that will improve dramatically. So that's I think trend number one. I think another trend with the whole topic of digitization and digital tools is real-time monitoring and adaptation of treatments. So, I mean, nowadays, still very often patients suffering from multiple sclerosis, they see their physician like every 6 months or something, and very often remains a little bit of a black box. What is happening in between? What is happening between those visits? But we now, all of us mostly, we have a smartphone. A lot of us are having smartwatches, wearables, where we are tracking a lot of different data on a daily basis. So I think we will get into a stage where really the individual disease course will be monitored more on a real-time base, or let's put it like in a daily or weekly base, instead of this 6 months or yearly interval, to really see, okay, here is something going on. Here we need to have a look on and adapt your therapy accordingly, or modify your lifestyle that you are being treated the best. And I think this access to technology will dramatically shift the way multiple sclerosis will be treated, not just within our Western society, but when you look into it globally, from a global perspective. Multiple sclerosis is such a complex disease. You need, most of the time, highly skilled and trained specialists to diagnose it, to treat it properly. So when you think about from a global space into regions with less economic power, there is a huge area where patients are actually being underdiagnosed and undertreated. And when you take now technology and AI into consideration, I think the knowledge of those MS specialists will really be democratized and can be spread out on a global scale to improve patient therapies globally. So I would say these are the top trends that I'm seeing, at least. But as I said, it's moving extremely fast. So most likely when we were talking 6 months, I will come up with another point because we have learned something tremendously new.
Yeah, so one of the things that happened to me during COVID-19 when we had to move during the pandemic, when we had the lockdowns and we had to move our annual assessments or our assessments even online, I got some of my fellows to develop a 3-stage neurological examination using a smartphone and a smartphone camera. And one was for eye movements and facial, another one was for upper limb function, and the third component was for, walking. And it was pretty good how much you could do using this video analysis. And so then what we tried to do was validate this versus our neurological examination. And I found out that the neuro exam has never been validated. It's just accumulated over centuries of clinical experience. And so the question I ask is, what is the gold standard for assessing the neurological system in terms of is it working normally or not? And I suspect this is where technology with AI is going to get rid of the neurologist's skill set, because at the end of the day, I'm almost certain technology is going to be much more efficient, first of all, and have much more sensitive ways of detecting abnormalities in terms of power, tracking visual fields, doing, all those types of things. So I can actually see tech coming to the table and using a neuro exam, and telling us that this patient is normal, within the normal range on like 10 out of 15 domains, but 5 out of 15 they're not, and they'll give you where they are on the domain and interpret it for us. I think that's going to come as well. It has to come, to be honest with you.
I fully agree, and that's super interesting what you're describing there, because I couldn't agree more. I mean, when you think about the neuro exam, when you think about the multiple sclerosis and EDSS scale, I mean, that's a very, very rough instrument, let's put it that way, that is really excluding a lot of the subtleties and nuances that are extremely difficult to measure. I mean, you don't have to go into the route, of course, about how do you really measure cognitive impairment, which is extremely difficult in general, but also subtle motory changes, stuff like that. It's very, very difficult. And very often, I mean, I don't even know how to see that, but in my personal experience, patients have actually been very often very good in telling you something has changed. It's you can't measure it objectively, but they are adamant and nope, something has changed, something is different, and I think technology will really aid us in identifying and tracking those very, very subtle changes over time.
Yeah, so I think one of the things the medical profession gets criticized for is when this thing happens, we see a patient annually or 6 monthly, and we say your MRI is stable, no new lesions, your exam hasn't changed, your EDSS score is the same, therefore you're stable, but the patient tells you, I'm not stable, I'm getting worse, my cognition. And, we say, well, because we can't measure it, you're obviously stable. And I think that's a form of medical gaslighting. We're telling them that we don't believe them in a way when they actually know that getting worse. And I think this is clearly a space where new technology and artificial intelligence can at least complement us and provide the evidence we need for monitoring the subtle ongoing progression or worsening of symptoms that we're not detecting with our history and exam, to be honest, with our examination. This is going to bring up a whole lot of issues. But don't you think, Benjamin, in terms of technology and low middle income or low income countries, that this could be a leapfrog technology? Because some of this stuff runs off a smartphone, to be honest with you. And because these people are getting access to smartphones relatively cheaply now, you could actually improve services in those countries very rapidly just by using a leapfrog technology rather than having to develop and change their whole healthcare system.
Fully agree. I couldn't agree more. This is exactly the point that I wanted to make. In regions where the healthcare system is lacking from resources or lacking from structures, Yeah, sure. Why do we have to build a very complex healthcare system, building a university medical center when it's just enough to give a smartphone to the patient? Absolutely. I think we have to take off our sometimes very Westernly biased glasses when we are looking into different healthcare system and finding solutions for different challenges, and technology and AI will and already is. I mean, you mentioned before the area of ophthalmology. That is an area where it is being applied already. I read about a project in ophthalmology in rural India, where there is a lot of diabetic patients out there, and nurses are scanning the retina of those patients. It's being analyzed by AI, and it's being identified if the patients are actually at risk of losing their eyesight due to diabetic retinopathy. So you don't need to have an ophthalmologist there. You don't need to build a medical center, because you can, as you said, you can bypass all that. And I think this will be an extremely valuable contribution to our global health in general.
Yeah, so another example was, I think the Bill and Melinda Gates Foundation funded, I don't know if you've seen these, they're beautiful devices, these handheld ultrasound devices that plug into a smartphone. They've funded a study in Africa, actually, where the midwives, they taught very rudimentary ultrasound techniques to scan pregnancies early on. And then what happens is the analysis of the ultrasound is done in the cloud using an online AI engine, and they're getting really, really good results. They're picking up issues that would not have been detected without the ultrasound device. So I think this is going to happen in MS and neurology as well. Yeah, the problem we have, though, who owns the data? This is one of the big problems about AI and real-world data, is when you collect all this data and it goes into the cloud and it's owned by a tech company, it raises all these ethical issues around who owns the data. Can the data be leveraged for additional innovation? What happens to the people the data comes off for? So I do think there are a lot of challenges around the ethics of this. And maybe you want to just give our listeners your perspective on what ethical considerations and challenges we're going to have going forward with real-world data and AI.
Yeah, you're absolutely right. It's an extremely difficult topic, and there are a lot of challenges when it comes to the ethical consideration. Of course, we are talking here about highly sensitive data, because yes, our own personal health is something that is just very personal. It's by definition most likely the most personal type of data one can imagine. And of course, there's always that risk of some sort of security and data breach, and that your personal information comes into the public domain. So I think two main things have always been taken into consideration. The one thing is technology in the sense of data security. So whenever you are dealing with real-world data, you have to do your absolute best and apply whatever technology is available to secure that those data are being stored, to use that phrase, in a place that is like the Fort Knox, that nobody gets in, that is not being allowed to get in there. That's, I think, the one topic. The second topic, of course, is, and this is for me way more important, is the topic of anonymization. Because most of the time when we are talking about medical relevant information, I don't necessarily need personally identifiable data around that. What do I mean by that? Taking me as an example, when I look into my medical data, it doesn't matter that I am Benjamin. That doesn't matter. It necessarily also doesn't matter where my exact address is. Potentially, it also doesn't matter what my exact date of birth is. It's important that I know that I'm 40 years of age. It's important that I know that I'm male. It's important that I know, okay, I live potentially in Munich, in southern part of Germany, whatever. These type of information are extremely important. So when you're looking into these real-world data, it's really to identify which part of the data that are really important, that are really personal, can be cut off to anonymize the data, that you can still make use of that. Last but not least, of course, informed consent. So I think patients should absolutely be asked if they want their data to be used for a certain purpose. But my personal experience is that when you're talking about patients with multiple sclerosis, they're extremely generous when it comes to the leveraging of their data. They really want to contribute. They really want to bring research to the next step. They really want that the fate that they have endured to some extent will potentially not materialize the same way for the next generation. So more often than not, I personally had the experience that those patients really said, hey, please use our data. And in the contrast, that they very often have been very active in saying, hey, we need to use more of the data that we actually have. Because, as I said before, when it comes to real-world data, a lot of the data is already there. So not using it would also really be a waste. It would be data that had been collected and you're not making use of it now. So you could argue, is that actually ethical to not use data that has been already collected? Another issue, I think, which is extremely important, is generally inherent biases within real-world data sources. And what do I mean by that? So, for example, take the example that I mentioned before in social media data. There are numerous studies outlining that women are way more present in social media conversations about health-related topics. So if you would build an AI model, for example, based on real-world data on social media, you would substantially underestimate the effects that are present in multiple sclerosis in male patients, in a population that is already smaller in multiple sclerosis in comparison to women. So you also have to take these type of biases into consideration. These are really extremely important topics, but for me, the only way to solve these challenges is, I think, in conversation. You have to bring the ones that are being involved at a table and discuss it with them, namely, primarily the patients.
Yeah, no, I agree. And I also think, the research framework we've done for biological specimens, in the sense that at the end of the day, the person with the disease, the patient, still owns their biological specimens, and they give you permission. So you as a researcher are the custodian of that sample. I think the same thing should happen for data. You're the custodian of that data. Even though you've used your technology to collect it, you don't own the data that belong. And this is kind of, I think, where the European Union is going with their legislation. At the end of the day, the individual owns the data, and if they want you to delete it, and that you have to have the mechanisms to delete their data. Yeah.
Exactly. So this is exactly what I wanted to say. I mean, this is basically the core, the two or three core ideas of the data protection law in the European Union, namely the GDPR. The one thing is you need to give in your consent that the data are being used. The second one is, yes, you own the data, even though you hand it to somebody else to do something with that. And the third pillar is that you can, at any point in time, revoke the right of somebody to use your data and have them delete the data. I think these are the three core pillars that are integrated in the GDPR. And I think they make a lot of sense, actually.
No, they do. And I think that's going to become the international standard. So I personally think the challenges from an ethical perspective will be overcome. And I think we also have the framework to look after people in, what I would call vulnerable populations, low, middle and low income countries, where we can also apply those principles. I think we're going to have some more podcasts, because I think we need to probably drill down on, one example, for example, in more detail, so we can actually show how a technology is going to impact on, say, the diagnostic pathway or the management pathway. I can see us talking about bladder dysfunction, cognition, etc., because I think, we've talked very generally, and I think, maybe the listeners want a specific discussion around one issue, diagnostics, for example, or monitoring. Anyway, maybe, Friedrich, if you could, just wrap up and just summarize in a few brief sentences the impact of real-world evidence and AI on the future of MS research and patient care, and then we close out.
Sure. So thank you for having that conversation with you, because I really think it's an extremely important topic, and you might have felt that is extremely close to my heart. So I think real data and artificial intelligence is at the brink of bringing us a revolution, and the revolution is going to change the way patients are being diagnosed, being treated, and being monitored. And to really summarize it into one sentence, for me, real data and artificial intelligence will be the absolute fundament that we get to our ultimate goal, which is personalized medicine. Because every patient is an individual and needs to be treated individually, because the root causes, the effects, and the outcomes are vastly different across patients. So we will get to a point where real data and AI will enable personalized, targeted diagnostic and treatments, where we also will get into the situation that patients are being taken care of on a daily basis, and that they get into a point in time where in the end, I think they become, even more as they are today, their own caretaker, their own guardian of their own health, because they are tracking and understanding their own disease and can navigate and manage it. So these are really the things why I'm personally am super excited to working in that field. And yes, I have been a working physician for 10 years, and I always will be from my mindset. So seeing the potential for patients to benefit from these technological advancements makes me personally really excited.
Thank you very, very much. I mean, I would just like to close out by saying, we talk about the Industrial Revolution, which is essentially mechanization and production lines, for example. Then the second Industrial Revolution was the development of the integrated circuit and computers. The third was considered information technology. And I think we're going into a fourth revolution in the sense of artificial intelligence and big data. So, if we want to engage with what's going to happen in the field, all our listeners, both people with the disease and healthcare professionals, should just realize we are at a transition period where I don't think healthcare is going to be the same in 5-10 years time. It's going to be completely transformed by technology and innovation and the use of AI and real world evidence, etc., in clinical practice. So it's going to be unrecognizable in the future. So I think you need to engage with this topic because it's going to transform the way you practice and live with your disease, or how you practice as a healthcare professional. And if you've got a disease, how you're going to live with your disease. Anyway, I'd just like to thank you for being with me today. We're going to have a whole series of these podcasts, and I can see this evolving into something long term. And I'd appreciate it if you could go on to the website and ask questions or send via the email address ms.innovationchallenge@roche.com. And also spread the word, share the link with your colleagues, and we'll hopefully evolve this into a really exciting series of podcasts. Benjamin, thank you very much.
Thank you so much, Gavin.